come to the operative note, the surgical note, which we generally write after we do the OT. So, operative notes are an essential part of medical documentation for the patient undergoing a surgical procedure, and they are needed to establish a continuum of care with the members of a multidisciplinary treating team. Like, for example, if a patient comes to you with a recurrent inguinal hernia, you would like to know how many years before the patient have had a hernia, what kind of hernia was it, whether a mesh was put in or not. So that becomes a very important document which will help you to formulate the future plan of this patient. And as I've already mentioned, that we are into an era of a rising medico legal conflict where a well written, legible surgical notes are very important, which will, form a part of the surgeon's defense. So the writing of the operative notes, it varies from place to place, and you already know that various hospitals have their own set format of writing. But the Royal College of Surgeons has set down a set of 27 variables which are to be, incorporated in a discharge summary. I have put down all these 27 variables. You can go through these variables after the class is over. So let me discuss these in detail. So the components of a well-written operative notes include the date and the time of the procedure. If you know, we always do a time in and a time out. So, what time the patient was taken inside, the anesthesia procedure was started, and what was the time of the finish. So, the date and the time of the procedure is important. Then, the patient details. Always check the hospital sticker along with asking the patient what is his or her name, the handwritten patient details, the staff details, who are the operating surgeon, who is the assistant surgeon, if the patient has been admitted under some other general physician, who is the consultant overseeing, and the anesthesia team. Then comes the diagnosis. What was your preoperative diagnosis? What was the postoperative diagnosis? For example, in a case of inguinal hernia, the preoperative diagnosis sometimes we write as a right sided inguinal hernia. After the surgery is done, where you know whether it was a direct or an indirect hernia, whether it was incomplete or not, whether it was complicated, what was the content of the hernia, everything has to be written in detail in the postoperative diagnosis. For example, in gallstones also, you would mention if it was a solitary calculi or it were a multiple calculi or there was a polyp, there was not a calculi at all, or there was sludge content. What was the wall? How was the wall of the gallbladder? Was it unusually thickened? Did it look anything, ominous? So all these have to be written in the postoperative diagnosis. Then you would mention the full title of the operation which is to be carried out. Never ever omit the site and the site specifically in surgeries like which are bilateral for like extremities or inguinal hernias. Always do mention the site. Don't use any abbreviations. And the type of the anesthesia, if you are giving a regional anesthesia or a general anesthesia. Then comes the operative findings, the visual examination and the palpation finding. For example, if you are doing a colonic CS surgery, what you see after opening of the abdomen, was there any abdominal collection? Has there been any perforation? Is there any bleeding? What is the position of the tumor? After that, when you palpate the tumor, how does the tumor feel? You know, all the pathological findings which you can see. Are there any nodes or not? Has there been any mesenteric fat standing or not? All these are very important. Any relevant negative findings which you get, as much detail of the possible you have to mention about the site, the size, the color, and the volume of the structure which is involved, and any difficulties which you have encountered while doing the surgery. What is the amount of the blood loss? These are all the operative findings which needs to be documented in detail. Then the surgical steps. You should never do a shortcut in writing the surgical steps. You start with the position of the patient. If the patient was put in a supine position or a prone position or was in a Trendelenburg, reverse Trendelenburg position, whatever it was, the part preparation and the draping. and the incision, what instrument you used. Some people prefer diathermies, they directly use diathermy these days, or a scalpel. You must mention that. Step by step description of all the surgical steps undertaken. Sometimes in the surgical steps, we just write laparoscopic cholecystectomy done or in inguinal hernioplasty done. No, you have to say that you have dissected the Callot's triangle, you have clipped the cystic artery and the cystic duct separately. Sometimes the situation are such that you need to leave the posterior wall of the gallbladder and come. So you have to mention all these steps in detail. That is very important. What are the sutures used? What is the type of suturing you did? Like in cases of hernia, what suture you used to fix the mesh? What sutures you used to close the sheath? If they are absorbable, non-absorbable suture, the number of the sutures is also very important. And after that, if we use any drains or any catheters or stomas, what is draining at the end of the procedure? Any sample which you obtain, if you obtain mesenteric lymph nodes for biopsies, piece of liver for biopsy, or a pus, you have to mention these specimens, which will go for a histopathological examination. And at the end, which is very important, is mentioning of the count. This most of the times we skip. You count the needles, the swabs, the mops, gauge, and instrument. You should always give one sentence at the end of the surgical procedure: instrument count checked, mop count checked, and gauze count checked. This is very, very important. This documentation is extremely important. And then we do a post-operative plan. In our language, what we call the post-op advice. The post-op advice, you people already know, comprise of the analgesia, the antibiotics, the anti-emetics, the VTE assessment. If you have used a thing like a sequential compression device in the OT, if you would like to continue using that at least for the first operative, post-operative night, or if you have given a Clexane injection preoperatively, when you plan to start it post-operatively, if at all, if the patient has been on ecosprin, when do you plan to restart that ecosprin? These all things go in the post-op advice. The catheter management, if you want the catheter be taken out the next morning, if you want a clamping of the catheter, okay, if you want the documentation of the urine output, details of the specific drains, dressings, packs, and device. When you want the drain to be emptied, what are the contents of the drains? So the details of the specific drains and when should they be removed, their contents to be documented, when to empty the drains, samples for the lab, if any, if you want to send. Sometimes we send drain fluid for amylase in pancreatic surgery. So you need to mention this in the post-op advice. And a routine post-op care and close monitoring, what which you want your nurses to do, like monitoring of the blood glucose level if you want, because that will help you in choosing whether you would continue using insulin, a sliding scale, or you would now like to switch over to the oral hypoglycemics. So these all information, they need to be well mentioned for your nurses to understand. And the final part is the signing off, where you sign your full name and you leave your contact details in case the nursing team wants to contact you.